Our next session today is on paediatric cancer, and our two chairs will be Leila Hessisen and Sumit Gupta. Over to the chairs.
Thank you very much. It's an honor, a pleasure to be connected today with you. Thank you very much for the aortic team for giving us this opportunity to report about the challenge of access to drugs in Africa and other low middle income setting. So for today, I will first of all introduce our session. My name is Leila Hessisen. I am pediatric oncologist from Rabat, Morocco. I am the past SIOP Africa president and the current Francophone African group of pediatric oncology president. So the first presentation will be from Professor Khama Rogo about the challenge of access to cancer drugs in Africa. Then we will hear from Avram Denberg about the access to essential childhood cancer medicine in Eastern Africa. The presentation after will be done by our colleague Lorna Renner about essential medicines in Ghana. Then Joyce Balagadi Kambugu will present about the cost of Burkitt lymphoma treatment in Africa. And the last presentation will be a report from the Francophone African group about access to drugs. So access to drugs is a core issue in access to care for childhood. It's really a challenging issue because it's not only one domain, it's 5 core domains of access. We got to ensure availability, accessibility, affordability, and acceptability and quality of drugs, which is quite challenging. Without good drugs, we cannot treat our patients, and even we can lead to a toxicity if we are using inadequate drugs. And in all the African countries, it's a challenging issue. So to begin our session, our first guest is the eminent Professor Khama Rogo. Professor Khama trained as obstetrician, gynecologist, and later learned his PhD in gynecology and oncology in Sweden. He had a successful academic medicine career in the 3 continents, and he embarked in international health, where he has been a powerful voice in productive health and rights for over 2 decades. So Professor Khama will begin this session by a presentation about the challenge of access to cancer drugs in Africa. Professor, it's an honor to have you with us today. Thank you very much for accepting our invitation. We know how busy is your schedule, so please, would you like to share your screen?
I would like to share my screen if you can hear me, but the bandwidth of where I am in my village, if I do that, you'll not hear me. So okay. If you don't mind, I will talk with you and give you a quick rundown on what is there. I apologize because you will miss my handsome face, but the facts will remain the same.
Thank you very much, Professor. Go ahead.
So if we are clear, first of all, thank you for the honor. But most important, thank you for making this topic top of the table, because it's something that is rarely spoken. I will raise 10 points during the next 15 minutes, and I want you to mark them very, very carefully. The first point is that the challenges of medicines for cancer in our region are not siloed. They are actually systemic. So you cannot discuss this without looking at it through the lens of the different building blocks of health as WHO puts it. So I will use that to illustrate exactly why the problem has to be seen in a much more integrated and comprehensive manner. First is that the problem and the challenge is a challenge of governance. And in this particular context, the governance question that I put on the table is, in the policy and strategy in our countries, where does cancer sit? Is it really given that priority in terms of the national policy and national strategy? Because it is upon those two that issues around financing and so on will come on board. We are still a continent that relies a lot and focuses a lot on infectious diseases, and is until recently, the non-communicable diseases have not been a top priority. So the governance discussion of the sector still are not embracing cancer in the strong manner that it should be. And that is not surprising. Number one, many of you oncologists are very, very few. And many of you are far too busy to get involved in the governance, policy, and planning issues of your countries. Agreed, there has been recent attempts at coming up with national cancer policies and even strategies, but oftentimes you'll find that it is a sideshow. It doesn't come in during the annual budgeting. It doesn't come in during the 4-year strategy planning and so on. And often, unless a donor supports those meetings, nothing happens. So our governance must first of all be able to put it a priority if we are to address the challenge. If it's not on the table, nobody addresses it. Secondly, our challenge is a challenge of data. Data is so little and so scarce that you can hardly use it for planning, leave alone for forecasting. So even as we talk about cancer, how much cancer are we expecting in the next year, 2 years, and 3 years, so that we can start budgeting for it? How much are we going to ask for? For which types of cancers? For which kinds of drugs are we going to do that? Given that you're already dealing with a system that is constrained financially and in planning and human resource, if data is missing, then it is likely to be thrown out because there is no evidence that you need this. So where is the data that would make it possible for us to plan, budget, and very, very efficiently use the little drugs that come our way? It is not enough to get a few drugs here, give half the number of courses to this baby or this child who requires it, and then stop midway. That is a waste. And unfortunately, that kind of waste is far too more common. No wonder often when we look at a lot of the African series in treatment outcomes, you will find that for most hospitals, the word lost to follow-up is the most common. Big numbers of patients are lost follow-up. What that means is that treatment was started, but it was not completed. And when you don't complete the treatment, then you can't say that you used the few dosages that you had usefully. So data becomes central to the challenges of access to drugs and even getting it. Third is service delivery. Until recently, but still in most countries, where is cancer treated? Is it in one big hospital, one big cancer center, or is it all over the place in a district hospital where there is some new specialist who's gone there and therefore has found a case of leukemia or buckets and knows what combination of drugs to give at that? You look across the continent and you find that there are very, very few really, really big cancer centers that are in control of the majority of the patients that they're getting. Now, if we are going to be treating all over the place, then we're going to have major problems in planning. We're going to have better problems in budgeting because we have a decentralized health system in most countries. Does the purchase belong to the district or does it belong to the national level? And if it's at the national level, how do we take it to the district or where the treatment ought to be? But if service delivery is not organized, like Uganda have tried, then we will continue having intractable problems of access to medicine and even being able to get it to the patient. The third area is the human resource area. Who is the oncologist in Africa? Is it the person who has had the kind of specialty that you and me have? Or is it delegated because we are so few to somebody else? And what is that level of delegation? And what are they allowed to prescribe? This is not clear in most countries. And so long as many people are prescribing without clear clarity on the quantity that is available and the quantity that will go out, we have a problem in that area. So reorganizing our service delivery sets in oncology, pediatric or otherwise, becomes central to solving the problem of availability and the problem of access. Third is the infrastructure. Now, infrastructure here, most people would look at it when you're talking about drugs in terms of the central medical stores and where there are stores and everything. I want to bring this one together with the supply chain. That if you have these drugs, where are they stored? And how do you get them to the patient who is out there in District X? This becomes a problem. Africa is still trying to find a way on how to handle drugs and the supply chain. The concept of central medical stores has not worked very, very well. And this has brought in a lot of delays. Even when drugs are available in the country, the distribution chain just doesn't work. So that infrastructure that is linked to the supply chain is still largely non-existent or far too weak, not just for cancer drugs, but all other drugs. But it becomes even more formidable when you're dealing with cancer drugs because of the nature of the diseases that we are training. So we have infrastructure, supply chain issues that come right from the area of manufacturing, because hardly any of the chemotherapeutics are manufactured in Africa, hardly any. Most of them have to come from outside. And then when they come in, then comes the question, what is the port of entry? Where do they get stored? How do you move them safely from one place to the other? How do you make sure that they are not expiring in one hospital when the next hospital doesn't even know that they exist? A major, major problem for us. Within that problem, then, let me look at the next problem, which is the pharmaceutical commodity problems itself in our country. You may know that the cost of drugs in Africa is absolutely inflated. If you take paracetamol, for example, the cost of paracetamol in DRC Congo is 15 times what it is in India. Why? Because of the number of middlemen that are there. Between the manufacturer and the person, the user of a drug in Africa, there's at least 10, 15 middle persons. In India, there is 2 to 3. If each one of those adds a cost to them, then you can understand why the cost is impossible. And that also comes in then with the quality of what they bring in. For so long as you have all these middlemen, what do they bring in which has expired? Which are the drugs that are counterfeit? These ones are not clear because of this big number of middlemen. Those middlemen bring in 3 challenges. 1, the challenge of quality. 2, the challenge of cost. And 4, the challenge of constant availability. They may bring in a batch this year. The next batch is coming next year. What happened in between? There is no accountability when you're dealing with so many middlemen. And this calls for a replanning. How do we work directly with manufacturers? Since most cancer drugs are not out of anyway, and therefore sometimes getting some of the cheaper generics is not there. How do we do this? That's a big problem that we have to address. Finally, we have to ask ourselves this question: who pays? The problem of finance. We still have in vast parts of the continent the reliance on the old systems of government providing free care. So people walk to the hospital expecting that they'll walk out the best treatment and with the drugs. Very few countries have gone into social health insurance where somebody goes with a card and they're guaranteed payment. In both instances, things are in a mess. Given the cost of cancer drugs, most procurements would rather not buy them because it is cheaper to buy anti-malarials and anti-helminthics. So the financing of our health sector does not allow guaranteed supply, continuous supply of cancer drugs. However, would social health insurance solve it? Probably and probably not. I have the experience in Kenya where we are in the process of expanding social health insurance and mandating it. And one of the areas that still are a problem for us is the management of non-communicable diseases, cancer being at the center. The insurance systems simply find that the cost of cancer treatment is too much for them. So they'll only want to pay partially part of it. This brings in the whole question that so long as our cancer patients are supposed to fund the purchase of drugs out of pocket, it is not going to be possible for us to give the quality of care that we want. So the financing system, health financing system in a country is extremely important. Now, who finances healthcare in Africa? The bulk of the money is out of pocket. The next lot for most countries is donor money. Donors don't put big money into cancers, they go into communicable diseases. And then the third lot is where the government budget comes in. And as I've said, the government budget is limited and constrained in looking after the other things that are on top of the table in the governance hierarchy. So financing becomes a big problem in how you finance, what you finance, how much you finance, and the regularity then with which you can be able to integrate the finance and the supply chain. Because if the procurement things doesn't work, then just having money is not enough. So we look at this, and I'm looking at the big picture, and I'm saying, in short, that if we are to sort out our challenges of the supply and availability and access to cancer drugs in Africa, then we cannot do it without a broader look at the efficiency of the systems. Because money might be there, but the other things are not working and it will not be there. Now, that may sound like I'm saying that it can never be solved. Absolutely none. What I'm saying is that it can be solved for so long as those of us who have the privilege of being the pioneer oncologists in Africa take time out of our very busy clinics to be part of the bigger public health discussion and agenda. Because therein lies our solution. You can complain the much that you want in your clinic, you can cry tears there, but for so long as you are not part of the big agenda of discussion, then you're not there. So is that opportunity there? Absolutely. Right now, under the discussion in UHC in Africa, so it's big, unprecedented opportunity for us to insert oncology and drugs and forms of treatment in. But unfortunately, and I'm talking about this or experience, when I work across Africa, very, very rarely do I find oncologists in the public governance and financing discussions of the continent. So I'm saying that for so long as you are far away and absent from those discussions, then you can only make the problem worse. It is not happening. Secondly, you can participate through research. How much of your research informs public discourse in your countries? There's far too much of it that is for the presentation in the big clinical event in New York or in Tokyo. But how much of it is there for the consumption locally? How much communication are we doing locally? I must say that some countries that have strong organization of patients with breast cancer, patients with cervical cancer, and so on, these ones have been stronger in public discourse, the specialists themselves. So I'm still looking for that specialist who will serve Africa and the African cancer patient well by being able to walk and chew at the same time. Remain clinically sharp, do the research, but make sure that you are in the dialogue that will make things improve for the patient. I am running out of time, but I want to leave you with those remarks. They may not be as incisive as many of you may want, but I want to let you know that you cannot solve this problem from starting in the middle of it. You've got to get outside and understand the milieu in which cancer is treated in our continent. Thank you very much.
Thank you very much, Dr. Roga. I think despite the inability to share slides or to show his handsome face, Dr. Roga managed to give a more succinct and comprehensive overview of the issue and set up all the other speakers fantastically. So thank you again, and I'm sure there will be many questions about the wealth of knowledge you just transmitted at the end of the session. So it's my great pleasure to introduce our next speaker, Dr. Avram Denberg. Dr. Denberg is a pediatric oncologist based at the Hospital for Sick Children here in Toronto, Canada, with a specialty in solid tumors. He also has a background in research and training in health policy and a specialization in drug policy in both high, middle, and low income countries. So without further ado, Dr. Denberg is also a close collaborator and friend, so I'll let Avi take it from here to talk about some of the collaborative work that's going on in East Africa.
Thanks so much, Sumit. Can you guys hear me and see my screen?
Yes, very well. Okay,
great. It's a total honor and a pleasure to be part of this illustrious panel. A huge thanks to Leila for the invitation, to the aortic organizers, and it's really a pleasure and, as I say, an honor to share the screen and the time with such close and wonderful colleagues, Joyce and Lorna, Kama, and to meet Bertrand. And Kama is a very hard act to follow. He's basically said everything I wanted to and needed to, so I think we can almost end the session there. But he also did set up beautifully a number of the key things to think about when thinking about access to essential medicines, and specifically cancer medicines anywhere, but also specifically in Africa. And what I want to take us through in a few minutes today is a bit of a pediatric focus on that, given our session, and relate to you some early results from a study, a multi-center study that our group has done with some on the call and many colleagues throughout East Africa on access to central childhood cancer medicines in East Africa. And as I say, I'm gonna, sorry, just, can you see my slides advancing? It looks like it, great.
Yes.
Just some front matter very quickly, a bunch of acronyms from research funding and for affiliations, and no conflicts of interest to disclose. And I want to come back to some of Dr. Rogo's remarks, because really I think he hit on a number of the key points that we need to be conscious of when we walk through this session. When Dr. Rogo says I'm going to hit on some points and write them down, I write them down. And I think one of the main things that I've taken away from being a bit of an acolyte of Dr. Rogo's and learning from him is the critical importance of thinking in a health system context. This can't be thought of, as he said, as a siloed issue. It's something that runs to the core of and the root of how health systems are organized, governed, financed, etc. And if we're going to solve the problem of the supply chain and financing for drugs and beyond it, to really assure access in all the domains that Leila spoke to, we're going to need to think in health system context. And so this is just a quick high-level snapshot of some work that our group with many colleagues has tried to undertake in some different regions. Lorna is going to speak today to some findings from work on access to cancer medicines in Ghana. And I'm going to spend my time speaking about this multi-center trial in East Africa. So this is a work that started a couple of years ago at the urging of a number of colleagues in East Africa with whom we work closely, to say that if we're going to improve childhood cancer outcomes in line with the World Health Organization's Global Initiative in Childhood Cancer, a critical component of that is access to essential cancer medicines. And so with the group that you see pictured there, and there's too many to name, but I'll name some of the core people involved in the study towards the end of my slides. We planned and began to undertake this multi-center prospective trial across 5 nations in East Africa and 9 institutions in them, to try to get a really nuanced sense of access to childhood cancer medicines in health system context that involved a number of stakeholders from the national level as well as the regional level, all the way up to some international partners. The overall, and I'm going to fly through this because I don't have a lot of time, but I'll give you a high-level snapshot and hopefully we can have some time for questions. The overall design of the study was mixed methods in view of the need for both detailed granular metrics on whether or not drugs were available and at what prices, as well as I say, this need for understanding the problems in the context of the health system. So we undertook what's called a convergent parallel mixed method study that basically moves forward with both qualitative and quantitative data collection in tandem, and then seeks to integrate the findings from each at the analytic phase. And specifically what we were trying to understand was the degree to which national essential medicines lists aligned with the WHO essential medicines list for children, as sort of a normative barometer or normative scale for which medicines are essential and should be there in country, to try to understand the availability and cost of these medicines at the level of the institution and the level of the patient, and really try to explicate the determinants of drug access. And we did this through a number of semi-structured interviews and gray literature and policy document analysis, as well as with 12 months of prospective weekly data collection on pharmaceutical inventories at 8 institutions across 4 of the 5 countries in the study. This is a busy slide, but I just wanted to give a very high-level snapshot of the sorts of stakeholders either involved with the project at a planning level or at a data contribution level. And again, we can come back to this. And just to give a high-level snapshot again of how those stakeholders broke down in terms of what kind of folks we interviewed. So we conducted 82 key informant interviews, which is a really large and wide cross-section of key stakeholders involved in this issue across policy and regulatory authorities, service providers, local pharmaceutical manufacturers, and NGO and civil society partners. And this just gives a really high-level snapshot of our quantitative data collection across the 8 institutions in the 4 of the 5 countries that I mentioned. We've neared completion of data collection at all sites. We just have a few weeks of data collection left in one site, but this is a Herculean effort by many of our data collectors involved in the institutions in the study, and I just wanted to acknowledge them because this really took quite a bit of work by the large team involved. What we're hoping to do with this weekly data on drug inventory stocks and prices is understand the prices and the median price ratios by drug and site. And I'll explain median price ratio in a moment. To understand whether or not stockouts are predicted by prices of drugs and the efficiency with which drugs are procured. And then to see which drugs are stocking out most commonly so we can understand where some of the problems lie specifically and try to ameliorate them. This is the list of drugs that we collected data on in this prospective weekly data collection. And really it cleaves very closely to the World Health Organization's Essential Medicines List for Children 2019 version. It has all the cytotoxic medicines on the WHO EMLC that are currently listed, as well as a number of targeted therapies, immunomodulatory therapies, hormones and anti-hormones, and some supportive care medicines. And that list was worked on carefully with each of the local principal investigators of our study to make sure that it made sense in the context of local practice. So some initial high-level results. As I say, our data is still being analyzed, and we're a few weeks away from completing quantitative data collection and still analyzing that real wealth of qualitative data, but I'll present some really quick high-level findings. So the first is the degree to which national governments are prioritizing the same medicines that the WHO does. And here you can see we've undertaken to look at the alignment between national central medicines lists and the WHO EMLC in each country. And you can see quite a variable alignment. So in a number of countries, really quite low alignment in terms of how those lists are lining up with long lists of drugs that are not included on the national EML, all the way to some quite close alignment with the WHO EML. So real variance across the region that I think is an opportunity for a better alignment going forward through some regional approaches, and I'll come to that. And specifically highlighted here are some of the key medicines that are used exclusively in pediatric cancers or near exclusively in pediatric cancers that aren't on national essential medicines lists. And these are recurrent across most countries. And I think speak to some of the unique considerations that need to be taken into account in pediatrics that currently aren't being looked at in a number of these countries. And this is pretty typical or common findings that we're seeing across a number of different health system contexts and regions when looking at drug access for childhood cancers. This is a very busy slide and a very high level snapshot condensed down into a heat map of drug availability across the institutions we studied over time. And what you're seeing here is really 6 months of data for all of those key cytotoxic agents I listed in a couple slides prior. Green being availability, no being stockout, or sorry, red being stockout or no availability in a categorical manner. And what we're seeing here again is a really wide variability across institutions, even within the same country, of consistent availability of essential medicines. So in some institutions, there's fairly uniform and consistent availability with very little in the way of stockout. And in other institutions, there's recurrent, frequent, and deep stockouts that aren't being quickly resolved. So there's a lot to unpack here, and our team is working on that, trying to understand which drugs these constitute and how that relates to price, and to do some comparative analysis about significance of these findings. But this provides, I think, a first quick high-level view of the fact that drug access is very inconstant and inconsistent within the region across different institutions, and that we're really going to need some depth to try to understand why that is. And this is just a quick, again, high-level snapshot of median price ratios of key drugs that we've called here pediatric drugs, which is to say drugs used, again, almost exclusively in the treatment of childhood cancers, which comprise a subset of that larger group of essential cancer medicines. And a median price ratio is really just a simple ratio between the local or domestic price and an international reference price, with some normative thresholds put forward by the WHO and other bodies on what constitutes sort of an efficient price or efficient procurement. And there are different ratios given of less than 2.5 or less than 1.5, depending on whether the drug is procured in the private sector or public sector. And we used a cutoff of 1.5 to indicate efficient procurement or not. So basically what you're seeing here is different MPRs, different median price ratios, comparing domestic price to that international reference price for each of these drugs, again, across the different institutions, showing pretty wide variability of the prices that are being able to be obtained in these different institutions and how that relates to those international reference prices. So again, some efficient procurement, some inefficient procurement by international standards, and a lot of variability with an opportunity to seek to diminish that variability and achieve more efficiency across sites. Another very busy slide that I won't belabor, but I wanted to give a quick, again, view of some of the work that our team's undertaking, because I think this speaks to the heart of what Dr. Rogo was getting at in respect of infrastructure, health system planning, and the supply chain. So this is a schematic of the pharmaceutical value chain in Kenya that is premised on our document and gray literature review, as well as the interviews with many of the key stakeholders across the country, that tries to put together from the international through the national and then institutional levels, how drugs are being procured and paid for, and how they're getting to patients, and where some challenges in those pathways might be beginning to occur. And I just wanted to highlight the tremendous amount of work that went into this on the part of our teams and the real unique value of this kind of work, because while this slide's very busy and tries to do a lot, I think it really is trying to piece together the supply chain in health system context in a way that speaks to what Dr. Rogo was calling for that hasn't been heretofore done. So again, we can come back to this, I won't belabor it, but just this sort of work is being done for each of the countries in our study to try to give an overview of where the problems might arise in the supply chain and in the pharmaceutical value chain more generally. So here's again a summative slide that I don't want to go into too much detail. There's a lot of data here. This is a really quick and first attempt to try to encapsulate the dominant themes that we're seeing across countries from those 82 interviews, and prominent codes broken down in those by those themes across sites at the global, national, and then institutional or individual level. We're seeing a number of key things. Firstly, that the global policy environment and funding prioritization for childhood cancer is evolving, and there are some key strides that have been made there. But there are some key challenges in relation to global manufacturing dynamics of cancer medicines that are playing into access in health system context in East Africa. That national political will and policy prioritization remains a huge struggle, as Dr. Rogo alluded to, in many of these countries, despite the epidemiologic transition towards non-communicable diseases, given the double burden with infectious diseases. That there are some key weaknesses in procurement and supply chain that we need to better understand and unpack. And as Dr. Rogo said, data, that there are some real gaps in health information management and surveillance, and specifically in inventory management for cancer drugs that are constraining the ability to understand what is missing and why it's missing, and to forecast effectively for procurement going forward. So I've tried to distill some of that down into some dominant themes that we can think through today in our Q&A and our discussion time. And the first is at the national level, the second, the global pharmaceutical level, and lastly, the regional level, where I see really a window of opportunity for overcoming some of the gaps seen or some of the challenges seen at the national and global levels. The first, again, is, as Dr. Rogo spoke to, governance, the need for pediatric cancer policy prioritization and greater directives for coordination across institutions in each country and regionally, to really try to look carefully at supply chains and some of the inefficiencies in them, and to try to work to strengthen and close those links, recognizing that pediatric cancer is quite unique. And so, for instance, from the point of view of human resources and infrastructure, Dr. Rogo spoke to centralization versus dispersion of care, either at core tertiary care facilities nationally versus district level care. And for childhood cancer, given its rarity, often what is needed is centralized care, and this has implications for supply chain and for how that's managed. And then obviously variable health system capacities when thinking about delivery of care more broadly need to be taken into account when thinking about access. I've also mentioned very briefly that there's some issues with global supply, and there have been some supply disruptions with key agents. Dr. Rogo mentioned there's very little local manufacturing capacity in Africa and in East Africa as well. And so narrow international sourcing of drugs from international suppliers leaves many subject to interruptions. And I think, as Dr. Rogo also alluded to, there are many middlemen. So there's multiple actors here playing diverse procurement roles that creates fragmented demand and drives up price. The good news is that there's a real opportunity, I think, in the context of the East African community to take regional approaches to solving some of these issues. And there are some prior advances in the regulatory environment in East Africa, like the African Medicines Harmonization regulatory scheme and a legal common market that provide some ability to build on in terms of cross health system coordination to really build on regional governance and technical capacities. And we can talk some more about that in the Q&A if we have time. So this, I'm running out of time, but I wanted to give a high-level snapshot of some of the key findings and focus on policy levers and policy options that came out of some comparable work we did in the Caribbean region with a number of our partners. And I've put a link to our paper and a podcast on the paper there, because I think it provides, while a different context, some insight into how this kind of work can influence policy. Dr. Rogo mentioned that research isn't enough. We need to move research to policy and to advocacy for change. And our work is seeking to do that through really laying out policy options for different stakeholders and trying to work on knowledge translation efforts in tandem with research findings. So some policy considerations that we could take away and consider as initial next step. The first, again, data. So the need to improve data collection to understand going forward from a project like this, what inventories look like for drugs and what prices look like, and to improve on record keeping accordingly. As I mentioned, the data collection for this was a bit of a Herculean effort, and that's in part because the data inventory processes could be improved upon. And that's a real, I think, opportunity for next steps in terms of policy. Another is thinking about the unique regional aspects of East African community governance and leveraging that for pooled procurement. As I say, there's a regulatory and governance environment that already is primed for this. It would take a lot of political will, but there's an opportunity here that I think our evidence can help build on. And there's also a real opportunity to implement some better evidence-based forecasting, again, to Dr. Rogo's point, to know what's missing and to know what's needed in order to buy in an evidence-based way. And our group has also worked on a forecasting tool that's specific to childhood cancers and takes into account incidence and demographics in 200 countries worldwide. So it could be very tailored to countries in East Africa, and which we've already utilized to predict some demand and budget impact in Kenya specifically. So our work seeking to complete these regional and country level analysis in the coming month or two with a view to academic manuscripts and some evidence summaries for policymakers. We hope to hold a regional stakeholder meeting to close the circle on our initial meeting in Nairobi in 2019 this coming winter, and to undertake some knowledge translation activities through policy briefs, targeted updates to policymakers in the region, and some updates to our colleagues at the WHO in an ongoing way. So I'll stop there in recognition of time, but I just wanted again to call out this amazing study team and all our partners, because this really was a massive team effort. I've listed our site PIs there, of whom Joyce Kambugu Balagade is one and who's on this call, and our personnel, as well as our key health system partners, and you'll see Dr. Rogo listed there as well. And a special shout out to Dr. Katia Petrika, who has really been a driving force of a lot of this work as a research associate in my lab. So I hope I haven't taken too much time. I'll stop there and look forward to the rest of the session.
Great. Thanks very much, Avi. This is one of the few sessions I've been part of where the speakers have been exactly on time. Thank you for showing that work. I think we're going to be hearing a lot of it in the months to come, given the wealth of data. So it is my great pleasure to introduce our next speaker, Professor Lorna Renner. For those of you who don't know Dr. Renner, and I think there's probably very few of you out there who don't. She is a pediatric oncologist and the head of the pediatric oncology unit at Korle-Bu Teaching Hospital in Accra, Ghana, and a professor at the University of Ghana. Dr. Renner is a driving force of pediatric oncology in Africa, as most of us know, and has been recognized by multiple awards, including just recently the First Ladies Award in Ghana and the International Women in Cancer Mentorship Award by the American Society of Clinical Oncology. For those of you who have had the pleasure of spending any time in person with Dr. Renner, you'll know that her cell phone is constantly going off as she solves problems from all sorts of people every minute of every day. I'm surprised it hasn't gone off while she's been on this seminar. So with no further ado, I'll pass it over to Professor Renner to give us her presentation.
Thank you very much, Sumit. Thanks for those kind words. A bit exaggerated though. So let's see. I hope it should be slideshow. I hope you can see my screen.
We can, Lorna.
We can.
All right. Okay. Yes. Presentation mode. Yes. Good. So following Professor Karma and Avram's talk, it's a harder act to follow now. It's similar to what Avram has presented. This is data from Ghana. And we all, as we've been all told, obviously, we need to get context-specific information so as to craft out strategies to improve outcomes by improving access to medicines for children. This just shows Ghana. And this was a similar mixed method study, as Avram has explained, that occurred in Ghana between 2018 and 2019. We were privileged to have a fellow from their end, from PERC, Sick Kids Canada, and it was a quantitative assessment of drug availability and prices and qualitative interviews to determine the health system and socio-political determinants of access. So we looked at 41 cancer and supportive care drugs that were listed in the National Essential Medicines List for Ghana, and then we looked at the retrospective drug data, including the prices and stocks, for just over a year, about 15 months. And then the interviews were semi-structured, and there were about 21 interviewees, and including policymakers, health professionals, and civil society organizations. And then we also examined policy documents like the standard treatment guidelines as listed here. And we looked at the median price ratio, which has been explained already, and then we evaluated relationships between drug price and availability, and then the drug class and formulation availability, and the procurement efficiency. And the qualitative interviews, we used thematic analysis. Showing the results, out of the cytotoxic drugs, only 9 out of the 19 WHO listed on the essential medicines list for children were available on our essential medicines list. That's 47%. However, the supportive care drugs, about 36 out of 50, 72% were listed. Cytotoxic medicines were out of stock for a medium duration of 72 days, up to 311 days, and supportive care medicines for a median of about 31 days. However, despite this variation in stockouts, there was no significant difference when analyzed in the stockout days between cytotoxics and supportive care drugs. However, we found there was a positive correlation between the price of the drug and the stockout. And 29% of 38 drugs studied were subject to inefficient procurement. There was also a positive relationship between the median price ratio and the number of stockout days. This just shows graphs showing the drugs that had stockouts. You can see that things like supportive care, like paracetamol, cotrimoxazole, where there were no stockout days, but then other drugs such as morphine syrup and dexamethasone, there were huge stockout days over the 1 year, 3 month period. The interviews were to determine the determinants of childhood cancer drug access. And from this, there were two dominant themes, just as Professor Karma has spoken to us about. Lack of political and societal priority for childhood cancer due to competing health system priorities came out strongly as determinants for childhood cancer drug access. And this is associated with limited data. And there was also notice that the influence of policies and regulatory milieu also affected affordability, availability, and quality of the childhood cancer drugs. Now, when we tease it out a bit more, when we look at the political and societal priority for childhood cancer, most of the participants brought out the point that there was an absence of a dedicated, consistent focus on childhood cancer as a public health issue. And this obviously hindered on the establishment of national systems for data capture in order to forecast the need and obviously impact policy. And why is there such an absence of dedicated, consistent focus? Obviously, there were competing health priorities. We know that before things are considered priority, we have to look at the disease burden, the cost effectiveness of treatment, the return on investment. And in our parts of the world, availability of international donor funds is important and the degree of public awareness. We do know that our health system, like that in many LMICs, are largely focused on communicable disease control, health promotion, and primary care strengthening. There was the issue of inadequate awareness, knowledge gaps between health providers and the public. And then we can't emphasize it enough, weak data systems. Obviously, absence of data on childhood cancer is a cause and also a consequence of the very poor political priority. Now, when it comes to the influence of policy environments on cancer drug affordability, availability, and quality, the policies and the drug regulation and financing emerged as one of the principal determinants of childhood cancer drug access. Affordability. In Ghana, children with cancer currently do not benefit from treatment coverage under the National Health Insurance Scheme. And there are high drug costs because of various regulations, high import duties, drug registration-related costs, minimal drug pricing controls, and limited financing options. And it's noted that medicine prices in Ghana are unfortunately amongst the highest in Africa, with an estimated 50 to 200% of the price due to retail markups. The Food and Drugs Authority in Ghana has classified oncology drugs under the orphan drug category, and such orphan drugs are supposed to benefit from a discounted registration fee and then a decision by FDA within 3 months. Usually it takes over 6 months to get approval from FDA, but these orphan drugs are supposed to benefit from a decision within 3 months. Issues regarding availability. In Ghana, there's a lack of central coordination. Procurement is by private pharmaceutical companies for cancer drugs. Other drugs, which we know like malaria treatment, tuberculosis treatment, and other treatments are procured through the Ministry of Health. But for childhood cancer, there's a lack of central coordination. So it's poorly calibrated and highly susceptible to drug shortages and increased time from where it's manufactured to where it's utilized. And as a result of this, there's also compromise on quality because of high prices. So the private pharmaceutical companies will source for drugs at lower prices with most likely resultant low quality. This slide, thanks to Avi Denberg and Perk, shows the complex interplay of all of these on childhood cancer drug access in Ghana. So we can see the national policy and regulatory milieu and the regulatory bodies, the effect of the impact of WHO essential medicines for essential medicines list on what the policies that we have, the possible effect of the West African Health Organization, because it has the West African Medicines Regulations Harmonization Project, which is there to try to control prices. If it were effectively working, hopefully this would help control some of the drug prices. And then all of these, you'll see that there's weak data systems in the middle there, affected by the policies, regulations, and the weak data systems also impact the prioritization of childhood cancer, because if there's no evidence, then it's not highlighted. And then effects on the regulation and importation affects availability, affordability, and the quality. You can see they're all intertwined. And then the private cancer, we know that the institutions, the main institutions that treat children for cancer, get their drug supplies from the private cancer drug supplier. So you can see his impact on that. And we need data from these main institutions, which is supported in a way by some civil society organizations, but the data is still needs to be improved upon. And so that impacts weak data systems. And so all in all, you can see the nuances of political, policy, regulatory milieu, data, and institutional factors, determinants affecting drug access in Ghana. That's a summary of it all. So we do know that policy legacies, we've always had this system focusing on communicable disease control and primary care. And this has affected, obviously, NCD drug policy, including childhood cancer. And we've seen the close interrelationships between governance and affordability and availability and quality of drugs. There is, as was shown from the study, a limited alignment between the WHO list and the Ghana National Essential Medicines list. And then weak data systems runs throughout to compound this neglect. And lack of data that obviously limits the ability to be able to forecast accurately and procure essential childhood cancer medicines efficiently. The absence of a centralized public procurement means that there's really limited capacity for quality assurance. And with the multiple source private pharmaceutical companies importing drugs, they tend to go for low-cost alternatives, which are with weak regulatory private policies. And this leads to erratic availability and concerns of substandard quality. Strategies from the participants, they felt that strategies should focus on drug affordability, incorporating both the demand side and supply side reforms. And also, there should be attention to cost-related barriers and public coverage through National Health Insurance Scheme. And it's thought that that would significantly improve access to childhood cancer drugs in Ghana. Now, what were the recommendations? There were two major areas for recommendations from these qualitative interviews. With regards to the data systems and evidence for political prioritization, it was recommended that there should be the formal inclusion of childhood cancer in national NCD policy and planning. But obviously, how do you formally include it if it's not high, if it's not prioritized, and if there isn't adequate data and evidence to support its prioritization? And so there should be a development of a streamlined national and institutional cancer registration and data management systems, and strengthening of systems for forecasting pediatric cancer drug needs, and implementation of a good national centralized logistic management system. The other important area of recommendation was on the cancer drug affordability, availability, and quality constraints. WHO pre-qualification of essential childhood cancer drugs was felt that if that could be done, that would have a huge impact on the prices and the quality of the drugs that are purchased for the country. And that there should be ways to reduce the costs by decreasing taxation on imported drugs, and importantly, to coordinate public procurement of childhood cancer drugs, and inclusion of childhood cancer in the National Health Insurance Scheme, with trying to improve manufacturing to supply side by expediting FDA via approval processes. So those are the main things that have come out. These are my references. And thank you, obviously, to my colleagues on the call here, Avram Denberg, Sumit Gupta, Kadia, Rhonda Boating, who did this study for us, and all those interviewed, as all of them responded, none declined. They provided in-depth information. And thank you so much, the organizers of Aortic and all of you, for the privilege of presenting this at this session. Thank you.
Thanks very much, Professor Renner. It's quite impressive to see all the work that's been done, but also to see some of the themes that are constant between the jurisdictions, while still the jurisdiction-specific issues that people are encountering as well. So it's my pleasure again to introduce our next speaker, Dr. Joyce Balagete-Kambugu. I think if anyone were to be asked to come up with a list of the pediatric oncologists that are really driving forward care for children with cancer in East and Central Africa and beyond, Dr. Kambugu's name would be on everyone's list. So she is the head of the pediatric oncology unit at the Uganda Cancer Institute in Kampala. She originally did her training at Makerere University in Uganda, and then following that went to the University of Cape Town for her pediatric oncology training. It is a real pleasure to introduce Dr. Kambugu to talk about the cost effectiveness of Burkitt's lymphoma, so a malignancy-specific talk as opposed to these more malignancy agnostic talks. So Dr. Kambugu, please take it from here.
All right. Thank you very much for your very kind words in introducing me. And it's always a challenge to speak after such gurus have spoken, but I hope that at the end of this talk we will agree or disagree regarding the cost effectiveness of treating Burkitt lymphoma in Uganda at Uganda Cancer Institute. Before I start, I want to initially just thank the organizers of this Congress for giving us as pediatric oncology an opportunity to discuss this very important topic on access to essential medicines on our continent. So by the end of this talk, I hope that we will have answered this question: is treatment of Burkitt lymphoma in Uganda cost effective? And you have heard from the previous speakers about all the challenges surrounding this topic. So I wanted to set the context and just show everybody who may not know where Uganda lies. But now, following Avi and they might actually know where we are. We are a small country in East Africa, and we have a population of 42 million, and our average life expectancy is 63 years. And you can see from this graph here, that 54% of our population is actually children under the age of 18 years. And I wanted to also give some statistics to set the stage in which bucket lymphoma is treated in Uganda. We are a country with an average size of 4.6. We have one of the highest fertility rates in the world. And though most of our children enroll for primary school, a very small number actually go on to secondary school. Obviously, this has changed with COVID. The vast majority of our population are rural peasants, and 8.3 million of our population actually live in poverty. Our health insurance coverage is only 4%, and from the previous speakers, you can understand what impact that has on treatment of children with cancer. And only 3.5% of our population actually have non-communicable diseases, and again, you can see where cancer really lies on the priority list with regards to health. So Uganda Cancer Institute, where this study was carried out, is a tertiary institution that's owned by the government of Uganda. And it has a mandate, 4 prongs of the mandate is to provide comprehensive cancer care to Ugandans, to spearhead research in the area of locally occurring cancers, as well as conducting training in all areas that are related to cancer, and of recent also to coordinate national cancer control. The Institute receives about 7,000 new patients with cancer annually, of which 10% are children with cancer. So that's about 700 new children with cancer annually. And this is an institution that's probably the largest cancer treatment center in our region, certainly the largest in Uganda. And of the children who present with cancer, bucket is among the 4 most prevalent cancers, the others being acute leukemia, Wilms tumor, and rhabdomyosarcoma. I put in this snapshot just as a commercial break to show you what the institute looked like at the time that this data was collected. You can see here this little signpost from 1967 when the institution was founded. Somebody threw it away, and then a good Samaritan got it and put it on this signpost and on this electric pole here. And that building you see there is called the LTC, where the children were looked after. At that time, there was no dedicated children's service, so the children were in there with the adults and everybody else. So the ward looks like, and you can see me here in brown. I just come back from Cape Town, and I had to spearhead the creation of our children's service at this time. And so moving on very quickly. So this study was then conducted. This paper was published, the patient population that was accrued during this era, the cost effectiveness of treating bucket lymphoma in our country. And there were knowledge gaps that this study sought to plug. And up till now, or in that time, only 8% of our country's budget is actually spent on healthcare. And of these, knowing that 3.5% of the population are NCDs, you can imagine the prioritization of non-communicable disease, of which cancer is one. So resource allocation poses a challenge, especially in the absence of critical data, like Professor Kama noted. And already in Uganda and many other LMICs, there is this perception that interventions in cancer care, especially children's cancer that is usually very complicated to treat, that they are very costly, and yet return on investment is rather low. So this study set out to fill this knowledge gap and hopefully debunk this myth that our policymakers have. So bucket lymphoma was used as a prototype in this study because it's one of the most common childhood cancers in sub-Saharan Africa. And the treatment was defined as a care that was administered per local standards at that time. And we treat bucket lymphoma with a combination of 3 drugs, cyclophosphamide, vincristine, and methotrexate up till now, with triple intrathecal chemotherapies every 2 weeks. And we give a total of 6 cycles. So, and analysis was done from the perspective of a governmental organization, although you will see that it included some of the indirect patient costs that were available at that time. And WHO guidelines for economic evaluation, in this case, DALI, was used as a generic outcome measure. And this was important to facilitate comparison of results across a variety of diseases, interventions, and other health system contexts. So this study was conducted under the auspices of a collaborative project that we had going on at that time that we named the Bucket Lymphoma Project. And it was meant to optimize bucket lymphoma treatment at the Uganda Cancer Institute. And it included patients under the age of 18 who had a confirmed histological diagnosis on morphology alone of bucket lymphoma. We didn't have IHCs at that time. And this project accrued patients over a 3-year period, and all relevant ethical considerations were observed. And in the discussion, if anyone is interested in knowing exactly what was done to the patients, we can answer that. And so this is a schema here of what exactly went down at that time. About 214 patients were screened with suspected bucket lymphoma because that was always the entry point. And 9 were excluded because they lacked pathologic specimen. And 69 were excluded, that was about 30% because they had a non-bucket lymphoma pathology on morphology. The tissue that was gotten at that time was sent to different laboratories just to triangulate and make sure that on morphology, we actually were including only patients with a morphological diagnosis of bucket lymphoma. And so we ended up with 136 pathologically confirmed bucket lymphoma, and 14 of the patients either didn't consent or did not meet inclusion criteria. So that in the end, 122 patients were included. And so this is a slide that's showing how cost effectiveness was actually determined. And you can see here that the cost really was incurred in 3 broad areas. One was the variable costs, the fixed costs, and the family costs. And the variable costs was really costs on treatments that were incurred at that time, which I talked about, either supportive care or actual chemotherapy. And then there were fixed costs that really were personnel or institutional overheads. And then family-related costs were things like transport to and from the cancer treatment center and so forth. And then effectiveness was determined as overall survival of children in this cohort. So what were the results? This is a rather busy slide, but what it shows is a breakdown of these costs that were incurred at the Cancer Institute vis-a-vis the mean cost per treatment at an international level. And you can see in the boxes here that the variable costs at the UCI was about $350 per patient annualized, as opposed to a mean cost per patient at an international level of $1,086. And the fixed costs similarly were much lower at the UCI, 852 as opposed to international standards. And you can see, similarly in each of these boxes. And even the family transportation costs, $148 was much less than at international standard of 461. So in the next slide, I want to show this in a pie chart so that it can kind of visually represent this. And you can see in this pie chart that the variable costs in blue and the family costs in, I think this is yellow, and then the fixed costs, which I mentioned, institutional overheads and so forth, were in gray, and then orange is the personnel-related costs. And this table here is showing this in greater detail. And so you can see at the UCI in each of the columns that we actually had much lower costs for treatment of the patients as opposed to what is incurred at an international level. So this Kaplan-Meier curve is showing the survival of bucket lymphoma when everything has been done as it should be, and an overall survival at 2 years of 55% was achieved. And obviously here survival was dependent on stage, and early stage disease, stage A and B, according to the Ziegler classification, had a survival of about 65% as opposed to late stage disease. So the conclusion conclusion from all this is that bucket lymphoma treatment in Uganda falls way below internationally accepted costs. And all this is as achieving a survival of 55% at 2 years. And you can see here that DALI averted of $97 US. And Avi, who will be present in the discussion, can delve further into these implications if anybody is interested. So there were some limitations in this slide, in this study, things like data quality, because some indirect costs could not be captured effectively. So things like food, for example, could not be captured very well since some parents come with their chickens and so forth, which lay eggs, and it's difficult to quantify some of those. And also around the model assumptions. And then lastly, because the study did not explore the budget implications, the budget impact and opportunity costs of investing in childhood cancer. So what are the implications on policy formulation initiative from these results? One, childhood cancer treatment is cost effective despite its complexity. And two, this was a very important study for us as Uganda, but also for Sub-Saharan Africa, because for the first time it detailed evidence that investment in childhood cancer in our setting is actually economically defensible and impactful. And that investment in systems strengthening for childhood cancer will not necessarily be limited to children with cancer alone, because there are horizontal benefits. So it can have public health significance if you invest in this, because other children can also benefit from these with childhood diseases. So the implications on policy, one, that if you bridging the gap in survival between high-income countries and low-income countries in line with GICC target that has been set for us, will definitely require injection of additional resources. I think that is self-explanatory. And that the more that is invested in this effort, then the more the improvement in survival that will be registered. However, this will only occur until a certain point where there are diminishing returns, obviously, when more investment will not result in improved survival. But we are way, way below that threshold, which at this point has not yet been determined. But it should not deter us. So, conclusion, we did answer the question that yes, treatment of bucket lymphoma in Uganda is cost effective. There is objective evidence that can be used not just by Uganda, but by other LMICs, but importantly also by our international partners, which as Lona mentioned, are a source of financing for many of our healthcare related matters. So in conclusion, no child should die of cancer, in Africa. Cure for more, care for all. Thank you very much.
Thank you so much, Joyce. It's a pleasure to see you, and hope that we can meet in Uganda and have the opportunity to continue discussion, because this got not to stop here. This is a very important and interesting field in pediatric oncology, and we should put together all our efforts to go ahead and face all together this challenge. So I would like to introduce Bertrand Pourroy. He is a pharmacist in France, Marsilia, and he is in charge of the pharmacy and drug access in the African group of pediatric oncology. Thank you, Bertrand. You can go ahead.
Thank you. Hello. Thanks, Leila. I will speak about our experience in the Franco-African group about drugs procurement. So just some remembering about GFAOP. That is a Francophone group created 21 years ago by Jean Lemaire. And the vision, our main goal, is that African children with cancer must to be treated and cured in Africa by trained African teams. So it is a strong network with 24 pediatric oncology units, 18 countries, and almost 300 members. In the beginning, GFLP allows to treat more than 13,000 children in 20 years. About drugs, GFLP promotes several actions since years, and in these actions, we have to facilitate access to essential medicines. To do that, we organize from France since 15 years the shipment of medicines. These shipments was and is done through a committee that ensure access to these drugs, but also check that these drugs are of quality and are sent safely to oncology units. Of course, we don't decide from France what is good or bad for African units, but we cooperate closely with oncology pediatric units. So to explain briefly, our medicine committee exchange with tumor committee of the GFLP. These committees are managed by African specialists, pediatrics. And when we define their needs, a budget is allocated by the GFAOP board according to our financial capabilities. And the access of to essential medicine group will discuss with several suppliers that can be foundations such as Salma or NCCS, or more simply with central purchasing French central purchasing agencies such as UNIHA or CAP to obtain better price. When we have better price, we will work with the pharmacy, the humanitarian pharmacy of the Ordre de Malte that ensure pharmaceutical safe circuits to address drugs to units. This model is efficient, but even if we send all these references since years, we have some problems. Of course, our network is increasing year after year, and from around 10 units, we are now around 25. And GFLP spent more than 2 million euros since 15 years. Donations are helpful, but they are not absolutely stable in time. When we look more closely, we can see that there is discrepancies between needs and shippings. For instance, last year, we have fortunately good quantities for instance, prednisone or actinomycin because of our partners. but we also have big problems. No way to send, for instance, asparaginates or hydrocortisone due to the fact that France forbids exportation of these drugs, and so on. So clearly, it is for us a big problem, because this model is more and more hard to maintain, and we decided to develop new ideas. It is the objective of our strategic plan. The aim of this plan is to secure the drug supply chain locally in Francophone countries, and helping to manage the regulatory and financial constraints, and to help to develop these drug circuits locally. Of course, and it is maybe the main point, we have to involve hospital, and not only hospital, but mainly hospital pharmacists in this circuit in order to set up medication circuits in accordance with pharmaceutical standards, international pharmaceutical standards, and to ensure safe use of anti-cancer drugs. In whole dimensions, safe handling, for instance, but not only, to manage appropriately stocks and resources. So our first results is to develop a pharmacist committee. Nowadays, 4 countries are participating to this committee, but it is ongoing recruit. And the main point is to share expertise and experiences between pharmacists for all countries. For instance, we work with the French Society for Oncology Pharmacy, but also the Ivorian Society for Oncology Pharmacy. And we are still developing formation and training for local pharmacists, because without strong pharmaceutical circuit, there is no possibility to have a good drug circuit. So, for instance, we will create a diploma for oncology pediatric pharmacy for the next year. Of course, all these actions are made in alignment with the WHO GICC objectives. And to finish, as we are a Francophone group, I thank all my colleagues and friends of GFLP in French. Thank you very much.
Thank you so much, Bertrand. Thank you for giving us much more time for discussion. This has been a very interesting session, and it's really pity that we have only 15 minutes for discussion, because this session gives us an overview about what's happening in nearly all Africa, from both sides, Anglophone and Francophone Africa. We understand now that NGOs and parents should not carry the burden of the cost of drugs in pediatric oncology. And as Dr. Hamas says, it's important for us to involve the governments, and so they take the big part of the responsibility of making drugs available in the country, but we should learn one from the other and seize the opportunity of the WHO initiative to involve the government and improve access to drugs. I don't know if there is any question or comments in the chat.
Hi,
or comments.
Hello.
Hi.
No, there's at this point in time, there are no questions. So you can certainly go ahead and discuss topics between your team, and I could also ask the odd question if that's okay with you.
Okay, that's fine. So that's okay for me. So I have a question for Dr. Hama, and also I would like to have the insights from all the group. We have faced a situation where the government tried to improve the affordability of the drugs. So they decreased the price of the drugs, and at this time, the pharmaceutical company stopped bringing these drugs into the country because it was not interesting for them and the price was too low. So how can we balance between those two causes of the drug access?
Thank you very much. Shall I try and respond?
Yes, thank you.
Yeah, the first problem that I want to bring out is that we, the very well-trained oncologists, a few of us who are there in Africa, we are trained in some of the best institutions in the world. But we come back and work in our countries. That training does not equip you to come and sort out the challenges of setting up. And I think that that is where we ought to start. That does our very sharp clinical training equip us to come and really provide care in a situation that is chaotic. Two is that, as you've asked, some of the actions that are taken by the government are usually not well thought out. There's no point for a government to come out with a price control on a drug that it doesn't produce and a demand that he has no control over. If the government wants to reduce the cost of drugs, or specific drugs, then I think that across the continent now we have ways in which it can be done. And some of them were mentioned here by Avram. Number one, bulk procurement. That is extremely effective. For example, in East Africa here, it makes much, much more sense for the East Africans to buy together and then distribute internally than for every country or every institution buying on its own. During this study that has been shared here, I remember some of the discussion that we had with Joyce, and we found that the cost of some of the pharmaceutical items that they buy in Kampala is at half what we are buying in Kisumu, which is just across the border. And the vendor is the same vendor. This has nothing to do with the taxes and everything. It's simply that a trader is a trader. So when we are working with government, it is important that we look for solutions that can work and we learn from each other. There is no way in which a government can just come and say, this is the price control in this country, this is where you're going to sell it, without looking into what does it take to get that drug there. So bulk procurement is one, and it works. Two, I mentioned earlier, that Africa must start working on reducing the number of middlemen. That is where all the money goes. It's not even the tax. It is everybody who's putting it their 5% and their 5% and so on. So I do applaud the government that have tried to put price control, but when you have a commodity of high demand and limited supply, then price control never works. It's just basic economics. But one thing that can work is that Africa is very, very well organized in terms of regional bodies. The ECOWAS group in West Africa, the East African Community Group, the SADC group in Southern Africa. And a lot of them already have the market arrangements and the regulatory things in place. It's just a question of implementing bulk procurement, and we will be there. Of course, one needs to get the data. Of course, one needs to go out there and try and get the best possible discussions happening at the global level. Finally, there is something that I call, for want of a better word, market capture. We have market captures that in our continent that are linked to our colonial past. So if you go to Francophone Africa, and without apologies, I've worked across all the linguistic barriers, you will find that everything that they buy will be from France. It's extremely difficult to get an Indian product into a Francophone country. And yet we know that those products can be as good from India and can be gotten much, much cheaper. So we have to be smart and clever. We have to cut some of the colonial linkages and open up access to the best prices and quality. Thank you.
Leila, can I add one small thing to that?
Yes, sure, go ahead.
Because I think Kama's hit on all the absolutely key points for us to take away, and that's going to require, as logical as it sounds to do bulk or pooled procurement, it requires some moving of political mountains sometimes. But I wanted to inject a note of optimism here, in that I do really think, building on Kama's point, that the opportunity to leverage existing governance and regulatory structures at regional levels in Africa is critical. So I mentioned at the outset of my talk that we've done some comparable work in the Caribbean region in 4 or 5 countries, and are working closely now, and again, very fractured markets, separate parallel channels of procurement and importation and supply management that were creating a lot of inefficiencies, a lot of variability in price. We're working with the Pan American Health Organization now and trying to leverage their strategic fund, which is a mechanism by which bulk procurement is done for, to date, largely infectious disease drugs in the region, HIV, TB, malaria, to turn that towards use for pooled procurement of cancer drugs, and specifically cancer drugs for kids. And I'd say our health system partners there and PAHO are really excited about utilizing the data and that mechanism to do that, to overcome many of the barriers that Kama just outlined. And the only other, so I think this is possible. Well, even though it takes a lot of work politically, I think it's definitely something to angle towards. And East Africa and many of the other regions in Africa are set up to do this. The only other small thing I'll add is that we need to keep a focus. This session's on pediatrics. We do need to keep a focus on kids to some degree, because many of the drugs used to treat children with cancer are also used to treat adults. And so while you can capitalize on the larger demand available for those agents because of their use in adult cancers, that can often drown out the pediatric need. And so unless you either earmark funds or ring fence supply of those drugs for kids, oftentimes the drugs get used up for adult needs. So that's just another thing that needs to be accounted for when doing procurement.
Thank you very much. Avi, any comments or remarks from Lorna, Joy, Sumit, or Bertrand, there is few minutes.
Yes, Leila, this is Joyce.
We have still few minutes, so we go ahead,
Leila.
Joyce.
Yeah, thank you, Leila. I wanted to substantiate some of the things that Kama has been saying, which are very important. And we did, in our regional meeting, have some of these come out. So things like bulk purchasing and things like removing of the middlemen are very real things, because around 2014, 2015 at the UCI, with the budget that we had, we only were able to have about 30% availability of the drugs on the essential medicines list. And this was really because of the marked up prices. But since the policy changed in Uganda, with the Institute becoming an autonomous entity in control of its own budget for procurement of drugs, with the very same budget, we were able to go up to 80% availability of the drugs just by removing the middlemen. So that the unit cost, for example, of Viovin Pristine was like a tenth of what it was before when we had all these middlemen. So something like this, I think, is one opportunity that we need to be exploiting as Africa. The other thing that we leveraged to achieve that was the bulk purchasing. Because when we were getting our drugs to our national medical stores, and then they released all these small quantities, something that works very well for things like anti-malarials and so forth. We ended up having the anti-cancer medicines bought in very small amounts, and yet the shipping cost is the same. You know, if it's in a container, cost if you bring 1,000 vials, for example. So bulk purchasing was very important for us because we were able to argue for the release of all our drug money at the start of the financial year. And so we front-loaded all that money, and most of the anti-cancer drugs have a very high shelf life. And because middlemen have been removed and you're dealing directly with the manufacturer of the product, you're then able to determine that they bring you a drug that has a massive shelf life. You get all your medicines, and that drives down the cost because you're now employing economies of scale, you see. And so some of those were very important for us. And I think that when we have appropriate dialogue, like Dr. Kama has challenged us to stop putting our stethoscopes on children the whole day and lamenting, and actually get up there where things are happening, we can actually influence something like this. Yeah, so it's very, very exciting for some of these things. And I'm hoping that following this, as South Africa, for example, we can hopefully have this sort of dialogue at that level.
Thank you very much, Joyce. Any other comments? Sumit, Lorna, or Bertrand?
I think those are spectacular comments that I'm not going to try to add upon.
May I ask Lorna?
Yes, Lorna.
Lorna, you did mention, how are you, Lorna? Could you give us a sense of the Ghana Social Health Insurance Scheme, which I know very well, and where discussions can be strengthened to ensure that cancer patients, pediatric cancer, is covered under the insurance scheme? What are the dialogue challenges in using it? Yes.
Thank you very much. We've actually had quite a lot of discussions with the National Health Insurance Scheme, going all the way into Parliament, because we were told we'd have to get the Parliamentary Select Committee, Ministry of Health to sort of agree to include it. We've done that. Fortunately for us, I think before the close of the year, we may be hearing something positive. But all along, it was they kept on saying, fortunately, thanks to studies on cost effectiveness, which was very helpful. And also this study has helped with regards to advocacy. And so now they do know that it is cost effective, and the numbers aren't as huge as they think they are. And as I said, they're covering things like breast cancer, which is about almost $1,000 per dose for Herceptin. And they get it for 18 months, which is way beyond what a child with cancer, the normal Beckett or retinal or worms would require for treatment. So we're hoping for the best, but there's been a lot of advocacy. And I think the studies that we've done have helped a lot. Thank you.
Thank you very much.
Thank you so much, Lorna.
Leila, I'm afraid we're going to have to call it a day on that one because we've run out of time. But I'd like to thank you all very much for a very interesting session. And thank you, Leila, for chairing that. It was extremely well timed